Hi, I'm Dan Laheru. I'm a medical oncologist here at Johns Hopkins. I am representing 9 other medical oncologists here at our institution. I'm here to talk about chemotherapy for pancreas cancer. Chemotherapy has typically been used in patients with resected pancreas cancer, either alone or in combination with radiation therapy, and this is known as adjuvant therapy. Also, chemotherapy has been used either alone or in combination with radiation therapy in patients with locally confined pancreas cancer prior to surgery, and this is known as neoadjuvant therapy. Also in patients using chemotherapy and radiation therapy in patients with locally confined but unresectable pancreas cancer, and this is known as locally advanced pancreas cancer. And then finally in patients with unresectable but metastatic pancreas cancer, and this is typically with chemotherapy alone. Historically, chemotherapy has consisted of 5-fluorouracil, which is an older chemotherapy drug, but it works by preventing cells from growing and dividing. This was the only drug that was approved for many years in this country. And then in the 1990s, a new chemotherapy drug called gemcitabine was tested, compared against 5-fluorouracil, and was shown to be more effective. And so in 1997, gemcitabine became a standard of practice here in this country. For many years then, we have looked at new chemotherapy drugs and have tried them against gemcitabine-based chemotherapy, but there were really no significant improvements beyond gemcitabine. And so we were stuck with gemcitabine for many years, and until very recently, a chemotherapy combination which is known as FOLFIRINOX, which does not include gemcitabine, was tested against gemcitabine and shown to be more effective than gemcitabine as a single agent. More recently, gemcitabine has been tested with newer chemotherapy drugs such as Abraxane, and this was tested in a recent clinical trial, shown to be more effective than gemcitabine single agent. So now already we have 2 new chemotherapy combinations over the past several years, which was not something that we had available for patients until very recently. I think there's a lot of excitement in the field of pancreas cancer in terms of new treatment options for patients with metastatic pancreas cancer. I think really one of the real opportunities to make some advances that we've been working very closely with our colleagues in pathology and in genetics and in radiation oncology, surgery, and medical oncology, and have really started to understand the biology of pancreas cancer and how pancreas cancer grows and develops. And this allows us to test new chemotherapy drugs in a very systematic and comprehensive way. I think this is reflected on some of these newer chemotherapy combinations which have been identified just in the past few years. Pancreas cancer is a very complicated cancer in terms of management. There are many people who are experts here at Johns Hopkins, including our colleagues in genetics, in gastroenterology, pain management, nutrition, social work, medical oncology, radiation oncology, and surgical oncology, to the extent where having all these experts in the same room on the same day to evaluate and see patients is, I think, a tremendous advantage here. And I think that this allows us to provide a plan of care for patients all in one day, and allows us to collaborate also with patients' physicians back home, and so we can design an appropriate treatment plan for patients here and also closer to home. So thank you for your attention, and welcome to Johns Hopkins.